So let's talk about the selective COX-2 inhibitors. First of all, let's say which of the NSAIDs are the selective COX-2 inhibitors. The most important one is celecoxib. After celecoxib you have etodolac. After etodolac you have meloxicam. And these three NSAIDs, types of NSAIDs, these are selective COX-2 inhibitors. We want to selectively inhibit COX-2 isoenzyme because we don't want to interfere with the COX-1. Why? Because COX-1 has some housekeeping effect. Some housekeeping effect. So we don't want to interfere with this isoenzyme because of its housekeeping effect on some targets of body, for example GI, such as renal, such as platelets, and all of these. So we choose to have some COX-2 selective inhibitors of the COX enzyme. About these class of drugs, first let's say these class of drugs, they do not have any effect on at the normal doses, no impact on the platelet aggregation. So in normal doses, these selective COX-2, they do not have any impact on the platelet aggregation. Why? Because they do not affect the thromboxane A2. Why? Because thromboxane A2 mainly produced by COX-1 enzyme, and when you don't inhibit COX-1, so you don't have any effect on thromboxane A2, so you don't have any effect on platelet aggregation. I said before, at normal range of dose of these drugs. But conversely, although they have not any effect on platelet aggregation, but they do inhibit the prostacyclin synthesis. They inhibit this process. Why? Because this process, prostacyclin, produced by COX-2 mainly. So they inhibit the prostacyclin synthesis. Prostacyclin molecules have some very good effect on cardiovascular flexibility. So from that comes the theory that the COX-2 inhibitors, although they can protect the GI, for example, but they can have bad effects on cardiovascular system. Why? Because they have effect on, or they inhibit the synthesis of prostacyclin's molecules. Another thing about these drugs is the renal toxicity, and the renal toxicity of COX-2 drugs is similar to that of non-selectively. It means that all NSAID all NSAIDs, whether they are COX-1 selective, COX-2, or COX-1, COX-2, they are non-selective. All of them have renal toxicities, and it is similar between them. So let's talk about the first drug, the celecoxib. So about the celecoxib, we said that celecoxib is COX-2 mainly. It is very, very selective, more than 100 times more selective of COX-2 than COX-1. Celecoxib is used for severity types of inflammatory diseases like rheumatoid arthritis, like juvenile rheumatoid arthritis, like osteoarthritis, and so on. Many inflammatory process. The usual dose for celecoxib is 100 to 20 milligram BID. It means 100 to 20 milligram Q12 hours, one in the morning, for example, one in the evening. This is the usual dose of celecoxib. And sometimes in the clinic we use a regimen like this. We firstly give the patient 400 milligram of celecoxib first, and then Q12 hours we give the patient 100 to 200 milligram of celecoxib. That is another type of clinical practice of celecoxib. Another interesting thing about the celecoxib is that there is a data that shows celecoxib may have effect on some symptoms of schizophrenia. Schizophrenic symptoms. Celecoxib may have effect on schizophrenic symptoms, and the probably mechanism for these type of action may be the impact of celecoxib on neuroinflammation, because the celecoxib have some good effect on neuroinflammation. And probably of these from this mechanism, celecoxib has some good effect on schizophrenic symptoms, and that is an interesting thing. About the adverse effects of celecoxib, about the side effects of celecoxib, the only thing that is different from other NSAIDs is the lower GI ulcers or lower GI bleeding, we can say, and this is the only difference. And other types of adverse effects of celecoxib is similar to other non-selective NSAIDs, like we said before, renal toxicities, any impact on all the body from the NSAIDs. And just about the GI problems, we can say celecoxib is lower or fewer, associated with fewer ulcers. About some interactions of celecoxib, we can say celecoxib has interactions with warfarin. Celecoxib has interaction with fluconazole. It's an antifungal agent, and also it has interaction with lithium, so celecoxib has interactions with lithium, fluconazole, and warfarin, and can increase the plasma level of these drugs. Why? Because inhibition of cytochrome 2C9, inhibition of 2C9, and these are the interactions. So that was about the celecoxib. About other two of the selective COX inhibitors, meloxicam and etodulac. The points about these drugs very similar to other NSAIDs, and especially similar to COX-2 inhibitor celecoxib. And just I want to mention about some difference, and there's very little difference, and the main difference, for example, is about the dosage. The meloxicam can inhibit the COX-2 inhibitors at 5 milligram per day, so that is the usual dose, and it can increase to 15 milligram per day. It usually dosed at once a day, the meloxicam, and also meloxicam has fewer GI problems than other NSAIDs like piroxicam, like naproxen, and others. And all other the adverse effects of meloxicam is similar to other NSAIDs. Meloxicam can also inhibit the thromboxane A2, and we didn't see this particular part in the celecoxib that we were talking about. And meloxicam can inhibit thromboxane A2 and can have effect on the platelet function. The indication of meloxicam is similar to celecoxib that we talked before. And about etodulac, also we just have the problem that is different from other things. About etodulac, the problem of acute pancreatitis. So we just about the etodulac have the problem of, or we have the concern about the acute pancreatitis that is increased with this drug than other NSAIDs. And the usual regimen of etodulac is 300 milligram per BD. It means twice a day, 300 milligram. And it is also have fewer GI upsets. So that was about the selective COX-2 inhibitors. If I want to add some clinical pearls about these drugs, I will tell you in the future videos.